I'm Laurence Klotz at the University of Toronto, and it's a pleasure to have the opportunity to present the Sentinel platform from miR Scientific. My disclosure, I'm the Chief Medical Officer of the company. This data, which represents a number of years of development and evaluation, has just been published for the first time in the Journal of Urology within the last couple of weeks. The Sentinel platform is based on the analysis of urinary exosome microRNA. These microRNAs are extracted from exosomes, which are stable vesicles with packaged cellular information that are excreted by cells, and a typical cancer cell may excrete thousands of these per day. And these exosomes contain important biologic material, and in particular RNA, which is packaged in a non-random way in these microvesicles. And these RNA sequences can serve as biomarkers for the presence or absence of disease and disease severity. There's a number of different types of small non-coding RNAs. I think the key concept is that these are regulatory molecules. They don't code for proteins. They regulate the expression of genes, and they include microRNAs, which are involved in stability and translation of conventional RNA, of message RNA, CD box, small nucleotide RNAs, and hackabox microRNAs as well. So the assay uses a range of these different types of small non-coding RNAs. The initial work involved a genome-wide array of 6,600 non-coding RNAs that were evaluated for their independent prognostic value for the presence or absence of cancer and the presence of higher grade cancer using the Affymetrix gene chip. And from this work, 280 non-coding RNAs were selected, each one of which had prognostic value. And the power of this assay is that while the prognostic value of individual sequences may be modest, when these are grouped together, almost 300 of them, the predictive power is phenomenal. And the data I'm going to show involves the initial discovery cohort and several validation cohorts. And here's how the assay works. Urine is spun off, the supernatant, which is cell-free, is taken. This does not require a DRE prior to voiding. The exosomes are captured, lysed, RNA is extracted, and then quantified and subject to an Affymetrix bioanalysis and the sequences derived. And the next step is to take this massive amount of information and use an proprietary algorithm that's been developed by the scientists working in the company that take the results of these many sequences and derive a single score that dichotomizes the patient into the presence or absence of cancer or of higher grade cancer. And this curve shows the different microRNA sequences and the predictive value or the importance for segregating disease condition, for example, the presence of absence of cancer. So you can see they have a range of predictive value. The assay uses the information from all of these collective individual sequences. So initially, this was a discovery cohort based on approximately 230 patients, about 89 with no cancer, 144 with cancer, and then the bottom data is the patients who had grade group 1 versus higher grade cancer. And it is apparent that the power of this assay to segregate these patients into whether or not they have cancer or high grade cancer is really quite powerful. We then went on and did a case control study involving about 1,400 patients of whom 568 were biopsy negative. Now, these were men who had absolutely no evidence of prostate cancer. So in most cases, these were men who either had a normal PSA, who were being evaluated for other conditions, or who had extensive biopsies. Amongst the group with cancer, 437 with grade group 1, and somewhere between 66 and 162 with each grade group of higher grade cancer. The mean age was around 70. The racial distribution, around 5 to 10% were African Americans, and the PSA in the low risk group was around 6 to 7, with increase in grade. As you might expect, the PSA increased. And this shows the performance of this assay. So this is the testing data set, which means after the initial discovery data set, this was essentially the validation study in 300 men with no cancer and 300 who had cancer. And the power of the assay is very apparent with an area under the curve of 0.979, meaning extremely high specificity and sensitivity for the presence of absence of cancer. Now, of course, we don't want to find patients with cancer. We want to find patients with significant cancer. So a variation of the sequences that are used, using only the ones that predict for higher grade cancer, again show quite marked segregation of patients with and without grade group 2 or higher cancer, and an area under the curve of 0.976. This is based on about 300 patients. And finally, the high grade assay, which is to identify patients who have grade group 3 or higher. In other words, patients with really aggressive cancer, absolutely no question in these patients that they have significant disease. And again, powerful segregation, area under the curve 0.987, 200 patients in the grade group 1 and 2, 100 patients in the higher grade cancer group. This is a summary of the discordance. So an obvious issue with this data is that biopsy was the gold standard. We know biopsy is not that good for predicting final radical prostatectomy surgical pathology. These patients were quite well characterized. And if you look, for example, in the cancer versus no cancer assay, the PCa assay, somewhere between 6 and 8% false positive and false negative. And one explanation for these false negative and false positive results is that this represents the inaccuracy of the systematic biopsy. Similarly, with the clinically significant assay, 8 to 10% false negative and positive, and a little better performance with the grade group 1 and 2 versus 3 to 5 assay. We're currently doing studies using the assay to predict radical prostatectomy pathology, and that should get around this issue of the uncertainty of the correlation between the biopsy data and the radical prostatectomy data. Finally, how will this be used? In the hemoproliferative cancer field, leukemias and lymphomas, they've developed this concept of dynamic risk profiling using serial biomarkers for personalized outcome prediction. I think this is completely relevant to the Sentinel assay story. So you use the assay plus other data to develop a continuous individualized risk index, which determines outcome probability. So you can imagine a patient, for example, with an elevated PSA or a concern about prostate cancer. His Sentinel assay is negative, you follow him over time, or a patient who is on active surveillance for grade group 1 prostate cancer with a negative assay for significant cancer, and over time that biomarker changes and gives a signal that significant cancer is there with a high degree of reliability. This would dramatically change how we manage these patients. So to summarize, The analysis of microRNAs in urinary exosomes allows for a dichotomization of the samples into 3 assays: cancer versus no cancer, low grade versus higher grade, and low to intermediate grade versus grade group 3 and higher. The performance of these assays in this validation cohort of more than 1,400 men has demonstrated a very high level of accuracy and area under the curve. I think this assay, once it is further validated, will have a great future in terms of improving the management of men in whom prostate cancer is suspected or in whom low-grade cancer has been identified, and the question is whether higher grade cancer is present. Thank you very much for your attention.